Great. Well, we'll get started a little bit early. We're going to start off with Dr. David Rosmarin from Tufts University. David is an assistant professor and vice chair for research and education at Tufts. The excitement around topical ruxolitinib for vitiligo has really started with David, who submitted.
Good afternoon. Good evening.
I think that was a meet. I've heard him say that a few times. The excitement about topical ruxolitinib really started with David's submission to Insight, asking for the drug to initiate an investigator-initiated clinical trial, and that worked. Not to steal his thunder, but launched a phase 2 and then phase 2 parallel phase 3 clinical trials. With really exciting data, and I think we're all grateful to David for initiating this process and giving us potentially our first new FDA-approved drug to treat vitiligo. So I won't take up any more of his time. David, take it away.
Thank you for that nice introduction, John. I'm just going to share the screen to start the presentation. So today's talk is on efficacy and safety of ruxolitinib cream, basically presenting the phase 3 results and the 24-week endpoint. As you can see, this really was a global effort with a ton of terrific collaborators and other authors. Here are my disclosures. We know that the Th1 pathway is extremely important in the pathogenesis of vitiligo, thanks to the work of John Harris and others, basic researchers. And this Th1 pathway is dominated by interferon gamma activation, which subsequently signals through the intracellular JAK signaling pathway. CXCL10 can get activated, recruiting CD8 positive T cells, which subsequently kill those melanocytes, or the pigment cells. And it therefore makes sense to use a JAK1, JAK2 inhibitor like ruxolitinib cream to break up this pathway and this hyperstimulation. So we initiated the investigator-initiated study with ruxolitinib cream to try to repigment patients with vitiligo with some success. And there was subsequently a phase 2 dose ranging study which was also yielded positive results, where about 30% of patients achieved a facial VIS20 at the week 24 time point, about half the patients achieving a facial VIS repigmentation of 50%. And also we saw patients at the year mark, about 45%, achieved a T-VASI 50 or 50% repigmentation of the whole body. So after that dose ranging study, we initiated the phase 3 program, which I'm happy to present here today. The design is comparing ruxolitinib cream, 1.5% twice a day, to vehicle. And patients could enter if they had vitiligo of nonsegmental type. We also included adolescents in the phase 3 program, which were excluded from the phase 2. And patients were randomized in a 2-to-1 ratio, with the primary endpoint being at week 24. Subsequently, patients on vehicle were allowed to cross over into an open label active medication. And we don't have the 52-week results to present today, but that will likely come at a conference in 2022. Important primary endpoint is the F-VASI75, or 75% improvement from baseline in that facial VASI pigmentation score. The reason why this is used is because this was determined to be clinically meaningful based on prior studies, particularly the phase 2 program. Other key secondary endpoints, including the F-VASI50 as well as F-VASI90, the clinically meaningful T-VASI50, or 50% improvement in overall pigmentation, the patient-reported outcome of the vitiligo noticeability scale, with a rating of a lot less noticeable or no longer noticeable at week 24, and % change in baseline facial BSA. We'll also discuss the safety and tolerability after the efficacy endpoints. In terms of inclusion, again, I want to emphasize that adolescents were a part of this study. It wasn't just adults like in the phase 2. Another difference between the phase 2 program is patients were allowed to use ruxolitinib cream in the phase 2 on up to 20% of their body. In the phase 3, it was limited to 10% or less. Patients had to have a half a hand worth of vitiligo on the face and at least 3 hands worth of their total body surface area on non-facial areas. Patients were excluded if they had complete leukotrichia within any lesions on the face. Obviously, if there were other dermatologic diseases confounding vitiligo assessment, if they had previously used a JAK inhibitor, and also there was a washout for other common treatments such as phototherapy, calcineurin inhibitors, or corticosteroids. It was a global effort focused in North America as well as Europe, involving both academic centers as well as private practice sites. You can see here the distribution throughout the United States, Canada, and Europe. And a lot of efforts went into the study. In terms of the baseline demographics and clinical characteristics, the average age of the patients was about 40. We know that patients, about half of them developed vitiligo before the age of 20. About half were female, half male. There was a large proportion of Caucasian or white patients at around 80%. Efforts were made to try to capture patients who were skin of color. And the skin Fitzpatrick phototypes were dominated by 1, 2, and 3. In terms of the average facial body surface area involved, it was about a hand worth on the face and about 7.5% body surface area on the total body. On average, patients had disease for a little over 10 years. About a third to 40% were diagnosed in childhood. 3/4 of the patients had stable vitiligo. About a quarter had progressive disease. In the phase 2, we saw about 25% patients having autoimmune thyroid disease as a comorbidity. Here it was a little bit less at 16 and 21%. And the majority of patients had tried other therapies in the past, including calcineurin inhibitors, corticosteroids, and phototherapy, amongst others. Here's the results from the primary endpoint. We see that at week 24, about 30% of patients achieved that F-VASI75 in both phase 3 programs. This is also remarkably similar to the 30% F-VASI75 that was achieved in the phase 2 program as well. We also see similar numbers to the phase 2 in terms of the F-VASI50 and F-VASI90, with around 50% of patients and 15.5% of patients, respectively, achieving those endpoints. Now, one thing that's different, though, compared to the phase 2 program, is we do see a higher vehicle response rate. For F-VASI75, it's around 7.5% and 13%. In the phase 2 program, it was 0 patients achieving the F-VASI75 on vehicle. I don't know exactly why there's that difference. One could be, well, we had different patients entering the study. We allowed adolescents into the study. There was a difference in body surface area. There were different sites used for the phase 3 program. And another reason could be that the study was conducted in the times of COVID. And we know that some patients were a little bit hesitant about taking their masks off and having their skin evaluated. In some of the pictures, patients insisted on keeping their masks on. So that could have led to differences in evaluation in the phase 3 program compared to the phase 2. Maybe they were a little bit more cursory. Here's what it means in photos to some of our patients. And this is a 50-year-old gentleman who had vitiligo for over 20 years. And you can see significant repigmentation already at the week 12 mark. This continued on through week 24, although there's still some depigmented areas around the mouth, philtrum, chin. I also want to point out very good repigmentation on the neck, even though that's not part of the facial VASI score. We know from the phase 2 that continued use of ruxolitinib cream led to continued repigmentation. So I'm optimistic that with continued use, he will continue to repigment and achieve an even better result. Here's an example of an adolescent, a 14-year-old who had vitiligo for over 10 years. who started to repigment particularly well around the eyes, the nose, and periorally as well. Patients were allowed to apply ruxolitinib cream around the eyes continuously. It was safe to do so in the phase 2 as well as the phase 3 program. Now, ruxolitinib cream is not just for the face, it's for the whole body as well. Here we see that about 20 and 26% of patients achieved a T-VASI50 at week 24. Here's what it means in some pictures. In the challenging to treat area of the dorsal hands, we see some repigmentation. Also, the total VASI score for this patient decreased from about 4 to 2.35. This is somebody who did not achieve a T-VASI50, but still saw some repigmentation. Here's a popliteal fossa on a 66-year-old female who had disease for over 50 years, starting to repigment in a follicularly based way. And what I really like is the data on the vitiligo noticeability scale, which is a patient-reported outcome. Here we see about a quarter of the patients saying that their disease is a lot less noticeable or no longer noticeable. And what I find also interesting is this is a higher number than what we're getting for the T-VASI50 results, which indicates that there's something about our current measures which don't fully capture the impact it can have on patients. So I think this is really impressive results, and only at week 24, monotherapy. Here we see a decrease in facial body surface area with patients who use ruxolitinib cream compared to vehicle. Difference between Rux cream and vehicle is around 19% in both studies. In terms of safety, ruxolitinib cream was well tolerated. The most common side effects are acne at application site, which we also saw in the phase 2, and is about 5% of patients. In terms of application site pruritus, also about 5% of patients having that side effect. What's really important to note, though, is that whereas our calcineurin inhibitors and PDE4 inhibitor and crisaborole have very high rates of application site burning, we're not seeing that with ruxolitinib cream. The medicine has considerably better tolerability. Also importantly, we're not seeing any serious treatment emergent adverse events that were related to treatment. When plasma serum levels of ruxolitinib cream are measured, we see that the levels are well below the IC50 for JAK2-mediated change in the bone marrow. Labs were checked on patients, and here we have the CBC as well as the hemoglobin levels as well as platelets presented. And in the box plots, we see fairly stable numbers throughout the 24-week time period. So no clinically significant changes in these values. In conclusion, ruxolitinib cream demonstrated meaningful results, repigmentation in both the face as well as the whole body. The primary endpoint as well as all key secondary endpoints were met in comparison to the vehicle, confirming the phase 2 results. Ruxolitinib cream was well tolerated. There were no serious TEAEs that were considered related to treatment. I want to emphasize that these are the results after 24 weeks and with monotherapy. We know from the phase 2 that with continued use of the medication, we see continued repigmentation. So I'm optimistic that with continued use, and once we have the week 52 results, we'll see even better repigmentation for patients. Also, there's still a lot of information to gather. How will ruxolitinib cream do in combination with phototherapy? How do patients maintain the response with ruxolitinib cream? And so how do patients do in subgroup analysis on different anatomic regions and in different age ranges? So there's still a lot of information to process from what was gathered in the phase 3 program, but it's certainly very exciting, and I'm hopeful that this will be a medicine available for our patients to improve their quality of life. Thank you.
Thank you, David. Great presentation. We're a little ahead of schedule because we got started a little bit early, and thanks for staying within time, but that means we've got some time for questions. And so I'm going to start with Dr. Abdallah's question that she put in the chat. What's the state of activity of patients included in both studies in Ruxolitinib? So I believe with the enrollment of patients, what were you looking for in terms of activity?
So about 75% had stable disease, 25% had progressive disease as determined by the investigators.
Great. And a question from the Q&A box. Patrick is asking us to put questions in the Q&A box if we can. This is from Mohammed Al-Jasser. Amazing talk, thank you. Did you observe any improvement in periungual vitiligo? That's a tough, tough ask.
So that wasn't recorded specifically within the question, so I don't have any data on that. My strong suspicion is, given how challenging it is to treat the periungual area, that even if it was recorded in my own personal experience of using Ruxolitinib cream, that's a really challenging area to treat. While we can see some results on the acral surfaces, such as the dorsal hands and dorsal feet, it's harder to treat those areas, and the periungual region is even more challenging than that.
Probably the hardest area, I think, and any area without hair growth, and particularly the fingertips, I think are really tough. It's a big ask for any drug. I have a lot of times I have patients asking me, because there's so much excitement around JAK inhibitors, they say, is this finally going to treat my hands and my feet and my lips and my wrists? And I generally just tell them, well, this seems to work better than the other drugs that we have, but it still follows the same rules, right? So what the UVB and other drugs follow a certain number of rules that we get used to, and we prepare patients for what will respond and what won't. And although this appears to work better, Ruxolitinib still has to follow those rules.
I think that's exactly right.
Yeah, and you had mentioned that I think it's an important point that you mentioned toward the end, that UVB is not required for this effect, right? This is monotherapy, which is a huge question before the INSIGHT clinical trial with Ruxolitinib, whether all trials would have to incorporate UVB. And I think they answered the question that it is not required. More questions. This is from Thierry Passerone. Great talk. Did you see differences in responses between skin phenotypes, dark versus light skin?
So we still need to analyze that data for subgroup analysis, which will come. That was done for the phase 2 program. And with those smaller numbers, there were no significant differences between the different skin phototypes or different racial groups. But that will certainly be done with the phase 3 program, where there are more patients. So it'll be able to detect differences on a smaller scale. But again, from the phase 2 program, there were no differences detected.
And I've heard some people say that they felt that darker skin repigments better with UVB and existing treatments. Honestly, I haven't seen that at all. Whether I've got a redhead that I'm using a Woods lamp to try to see pigment, or really dark skin, I feel like everybody repigments in an equivalent way, but that's just anecdotal. I'm not sure your thoughts.
In my experience, it's been somewhat similar. However, from the data, there is a slight trend for the numbers looking a little bit better for patients who have darker skin, but that wasn't statistically significant. And we'll see if that trend holds in the phase 3. But in my experience, the response has been similar across all different groups.
And I wonder if it's more recognizable. You know, if you have really dark skin, you certainly can see the perifollicular repigmentation. There's very much brown spots everywhere, and it's hard to ignore. So maybe that's part of it. Dr. Azmat, Samia Azmat asked if that was combined with narrowband. I think we answered that question already, that it was not initially, but will be soon, right? Patients will be allowed in the extension to continue with narrowband. Dr. Rosalie Luton, are the patients continuing treatment after the trial? Did the repigmentation effect remain after stopping treatment? That's a big question.
Yeah, so that's certainly something we all want to know. There are and Dr. Passeron has done some great work on maintenance of treatment and patients, what % of patients can lose the response if the vitiligo is subsequently untreated. And from the phase 3 data, there is a specific portion at the end of the 52 weeks that for patients who achieve a certain degree of repigmentation, some will be randomized to continue treatment, others were randomized to go onto vehicle. So we'll hopefully answer that question in a very systematic way. However, from the phase 2 results, we did see some patients maintain their response, some patients lost their response. Because the numbers are small, it's hard to know exactly what the percents are. However, there is some hope that there are some patients who will be able to maintain their response, and that question will be better answered in the phase 3, but other parts of the program. And it is important. My personal thought is that many of the patients will likely have to use ruxolitinib cream, for example, twice a week for maintenance in order to maintain their response, similar to what theory showed that patients who used tacrolimus ointment twice a week also did better.
Right. Yeah. Thierry published that great paper that I put in all my talks now, because people always ask that question, what's the durability? And Thierry reported 40% relapse within a year of stopping therapy. And that's tough. You know, any observation to look for relapse is going to have to continue for a long time to really quantify that. And then showing that topical tacrolimus just twice weekly reduces that to under 10%, which is what you're referring to there. And I imagine the same will be true for ruxolitinib as well. And I use that all the time in my clinic. I tell patients you can either stop and restart, or you can stop and just use twice weekly. I also wondered too, go ahead.
Oh, I think one thing that it makes me a little bit more hopeful about maintaining a response is some of the ruxolitinib cream remains in the skin for a longer period of time. There's some depot, so that may allow us to maintain the response a little bit longer than tacrolimus, but we don't know how long. And also, if patients have progressive disease versus stable vitiligo, there may also be a difference there as well. That's what I strongly suspect. So if patients have progressive disease and they're getting new spots in other locations, I think it's less likely that they're going to be able to maintain the response as opposed to a patient who has stable disease.
Sure. And maybe we can get away with even less than twice weekly then. If ruxolitinib is creating a depot, that would be amazing. Patients are very happy with the twice weekly. And I extend his observation from maintenance to preventing spread too. I imagine if twice weekly is a good maintenance therapy, then I think if your goal is to simply prevent the spread on the hands because you've got no benefit for repigmentation, then I treat that way as well. We actually have a lot of questions, so 5 minutes left. Dr. Parsad, I think, was the first.
Excellent talk, Dr. David. Yeah. So just your experience on mucosal surface, like sometimes we use tacrolimus on the lips. Any experience for that?
I have never used ruxolitinib cream or any JAK inhibitor on mucosal surfaces. Part of the reason is due to concerns of systemic absorption, which was what we're trying to minimize with the topical formulation, but that wasn't allowed in my investigator-initiated study, the phase 2 or the phase 3 program. So unfortunately, I have no experience. I have no doubt that some people will try it. As John was saying earlier, though, because it's so challenging to treat mucosal areas in general, that's likely to apply for ruxolitinib cream as well, where it's still really challenging. And our other methods for procedural and melanocyte transfer are probably going to remain the treatments of choice for those really, really challenging areas.
Yeah, for better or for worse, I have treated the lips and have not seen much benefit. You get a little bit of marginal repigmentation, which is pretty limited.
So I thought this is a new molecule. I mean, if have some role in that way. I mean, thank you.
Yeah, that was our hope.
Yeah.
Okay, Dr. Esmat, question?
Yes, hello everyone. I just noticed that, I mean, if we can achieve this pigmentation on the hands, it is first of all, it's occurring in a perifollicular pattern. This means, I mean, when with phototherapy, of course, we will get very good results. I think, and if we can, did you start the trials adding the phototherapy with ruxolitinib or not?
So there is a study planned to look at ruxolitinib cream with phototherapy. In the phase 2 program, there were 3 parts. There was a dose ranging study, a more open label study extension through 52 weeks. And then in the last phase, there was a year where patients were allowed to add in phototherapy. We did see continued responses when patients added in mostly narrowband UVB to ruxolitinib cream. So there's some safety data behind its use in that regards, and we were seeing improved response. Also in our investigator-initiated study, we also had a portion where after we allowed monotherapy, we had patients use narrowband UVB. And even in patients who previously failed narrowband UVB with no repigmentation, when they used the two in combination, they were seeing response.
Yes, it's. I mean, the result of the face, which was totally depigmented, to be repigmented this way without phototherapy, but maybe it is the patient is exposed to the sun also. That's why the face has a good response, but it's really very good response actually, because he has been exposed to the sun for his life. But when he put the treatment, the repigmentation occurred. So they are very encouraging results actually. Thank you.
Thank you, Dr. Asmat.
One more question, Dr. Lapoule.
Hi, very exciting talk. Anyway, very exciting results. I wanted to ask about especially the patients with long-term disease and stable disease, just because, in the beginning, at least, we thought, oh, well, if you have, once you stop the T cells from actively killing melanocytes in the area, that that would be enough for melanocytes to repigment the area. And I'm just kind of trying to wrap my head around, in the case of stable disease where I would expect less active T cells to be present, what the thought is on how this would work. Do we still think that there might be some effect directly on melanocytes, or is this really T cells that are still doing something even though they don't actively depigment at that point?
Yeah, so I'm glad you asked that, because a lot of us thought that if patients have long-standing disease, they would be less responsive, or if they were stable, they would be less responsive. But it turns out that's not the case. In fact, there was a slight trend that the longer the patients had the disease for, they did a little bit better numerically, although that wasn't statistically significant. Additionally, what seemed to matter, though, is the age of the patients. The younger patients seem to respond better, and I certainly find that in my own population, that younger patients respond better than older patients. And once we're hitting the 70s or 80s, it's harder to repigment them, those patients. Now, the question of why do we see this trend and why does it not matter, which differs significantly from alopecia areata, I'm not sure. One possibility is there really is an immune response that's there, even if it's smaller at the edges. Two is that there may be a slight effect on melanocytes, although that is questionable. In the work of Angelina Cristiano, she did show that there was some promotion of MIT-F, LEF1 with JAK inhibition on at least in her mouse models. However, we're not sure if that's having any effect in the skin.
Thanks, David. Yeah, my bias is that there is constant T cell activity in stable vitiligo. The fact that the reason why it's stable is T cells are continually being activated and slowly recruiting more cells. And if that weren't the case, it would repigment. But I think we need a lot more studies on that. I think it's great news either way, clinically, that stable disease response. So we're happy to see that. All right, we have to move on. There is a comment from Dr. Singh that he has used Sorlia coralifolia on lips with sunlight exposure, and I think we've been using that for thousands of years, right? In the Iron Age, patients were using that, and through marginal repigmentation can get 70% of the pigment back, they said. So just a comment. Thank you, David. We're going to move on.
Thank you.